Okay. Hi, everybody. I'm Anna Harvey. I'm the president of the Social Science Research Council, and welcome to the Council's 10th and final Centennial Lecture of 2023. All this year, we've been celebrating the founding of the Social Science Research Council 100 years ago, as well as the achievements of the social and behavioral sciences over the last 100 years. And we've hosted lectures covering each decade of the Council's work, learning about the progress that we've made as a research community on understanding, and in some cases, providing potential solutions to challenges like poverty and discrimination and conflict. And we've now reached the most recent decade, the last decade of the Council's work and our centennial. And one of the most significant challenges that we've had to face as a society and really as a species, which was the global COVID-19 pandemic that spread so quickly in early 2020. I joined the council in June 2021, which was right about the time, if you remember, that the pandemic was supposed to be over. In 2020, we had, with remarkable speed, developed and tested and approved a number of safe and effective vaccines by December 2020. And in the US, the projection was that we would have 70% of the population vaccinated by July 4th in 2021. We missed that goal by a lot in many places around the country, and vaccination rates remained low, very low in many places around the world. So in June 2021, many of us had a growing sense of urgency that our investments in research and development for pandemic response had missed something important. We'd invested in R&D to develop and test vaccines, but we hadn't invested enough in R&D to develop and test the interventions that would convert vaccines into vaccinations. And without those effective interventions, we might not get to the levels of society-wide vaccination that we needed to be able to fight back the pandemic. So we at the council worked with a coalition of funders to launch a research consortium to develop and test interventions that increased vaccination demand. And in November 2021, we launched the Mercury Project to support that work in Africa, Asia, Latin America, and the Caribbean, and the United States. And the Mercury Project now, it's still going on, now includes over 100 researchers working in 18 countries around the world. They're evaluating multiple interventions to boost vaccination demand, including things like reducing the search costs of finding accurate vaccine information, reducing the decision costs of assessing the accuracy of multiple sources of vaccine information, reducing the logistical costs of getting a vaccination, and then increasing the social benefits from vaccination are the four main intervention categories that people are evaluating. And today, we are very fortunate to be joined by one of the world's leading experts on vaccination demand, Katie Milkman, who is the James G. Dinan Chair of Operations, Information, and Decisions at the Wharton School of the University of Pennsylvania, and co-founder of the Behavior Change for Good initiative there. Katie, who is also a Mercury Project grantee, is going to be talking to us about what have Megastudies taught us about successfully encouraging increased vaccination. And we're very glad to have her with us today. So you can post questions at any time as Katie is talking in the Q&A. And I'll share them with Katie after she winds up. We have about an hour, and we'll try to save about the last 15 minutes of that hour for Q&A. So Katie, thank you for being with us today. I'm really looking forward to hear what you have to say.
Thank you. Thank you so much for the lovely introduction. I'm really excited to have the opportunity to share the work of my team with this group today. So I'm going to go ahead and project my slides and get started. As Anna explained, I'm going to talk about what Megastudies have taught us about successfully encouraging vaccination. And I just want to highlight that this is work with an incredible team of collaborators. And in particular, I want to shout out to Angela Duckworth, who has really been my co-PI and partner in crime on all of this work, as well as the amazing staff at the Behavior Change for Good initiative, where we do the work at the University of Pennsylvania. So this setup actually was done largely for me. I was going to talk a little bit about the pandemic and take you back in time. We sort of already got there, but I'll still show you my first couple of slides, maybe in slightly less detail. We started doing work on vaccination very early in the pandemic, before there were vaccines, in fact. Having studied vaccination a little bit prior to COVID-19, though certainly not with the energy that we put into it once COVID-19 became a global pandemic, we recognized that there was going to be a problem even before world leaders were paying attention to this. So this is some data from pre-vaccine availability, going back all the way to July of 2020, when vaccines, we knew they were coming because there had been this incredibly successful mRNA work done in animals, and the phases were rapidly moving through human trials were starting. So everyone was getting very excited. And there was lots of conversation about how do we speed this up? Operation Warp Speed in the US was gaining traction. The next thing that people started talking about around June of 2020 on the global stage was, okay, how are we going to scale up distribution? Even if we warp speed through clinical trials and so on, how will we, make sure there are enough of them quickly and that they can be distributed quickly? And these are important problems. Don't get me wrong. We needed to solve those problems. But what no one was talking about back then was that we needed people to actually accept the vaccines. People needed to line up enthusiastically to take them in order for the pandemic to come to an end. And as behavioral scientists, it was pretty clear to us that that was going to be an issue. So actually in June of 2020, early June, we published an op-ed in USA Today. We wanted the maximum possible readership, and that was where we went with it, about the importance of actually figuring out how would we communicate effectively and thinking of that as a priority. Now, I wish I could say that government agencies all took great note and everybody came together and there was this massive effort to focus on that problem. It was really a year later, when they ran into the demand cliff, that people started paying attention to it. But the good news is we'd done some work prior to that I hope helped, and we've done some work since. So I'm going to tell you about the challenges we tried to overcome in our research. So first of all, the first challenge, of course, is a persuasion challenge. This is a really tough one, especially if someone has been, exposed to a lot of misinformation and has really adopted the view that vaccines are unsafe, even though they're extremely safe. So that's one challenge. It's the harder challenge. But there's a second challenge, and this is the one we felt was more straightforward and more in our wheelhouse. It was sort of the low-hanging fruit, if you will. And that is that many people who intend to take an action like get a vaccine never follow through. And closing that intention action gap turns out to be much easier than persuading people to change. So just to give you a little data on the scope of the intention action gap, here's a few different studies I'll put onto one graph, just showing that in many different domains, including in vaccination, and this is all data that was collected prior to the COVID pandemic, which is why I'm not showing you any COVID data. We knew that even people who said, yes, I absolutely intend to do this, follow-through rates can be pretty abysmal. Even in vaccination, only 78% of people who say I'm absolutely getting a flu vaccine end up following through and getting one, for instance. So that is the kind of gap. It's pretty easy to close. Now we just have to get you there, make it easier, make it less likely you forget, as opposed to necessarily persuading you to do something that you're dead set against. So we thought we would try to chip away at this particular gap. And specifically, we wanted to do it as fast as possible. We wanted to generate insights about closing this vaccine intention gap with, I will just say, an urgency that I have never felt in any of my past research on behavioral science, because we realized that this could make a huge difference if we got it right with the rollout of COVID vaccines. We thought this was actually a problem that was perfect for a new methodology that our research center at the Behavior Change for Good initiative is all about and has pioneered over the last several years, which is what we call a megastudy. So instead of testing a single hypothesis, as we often do when we're doing scientific work, I have an idea about how to close the action intention gap if I just send people a timely reminder and embed a joke in it, I can close the action intention gap. That joke will buzz around in their head, they'll remember it, they'll repeat it to others, and people are going to be more likely to remember and follow through. That would be a single hypothesis test. But we want to test maybe dozens of those simultaneously. We can run a mega study. And what this allows us to do is several things. First, and this is really important, it allows for comparability of results across different studies. So if your pet hypothesis has to do with telling people jokes, and someone else's has to do with communicating the social norm that it's becoming more popular than ever to get vaccines, well, we might never know who's actually developed a better insight. Maybe both work, but you run your test in California, I run mine in Vermont, and we don't have comparable populations. We maybe look at different follow-through periods and different data sets. Who knows which is more cost-effective? But comparability of studies is guaranteed by a mega study because everyone is sort of running in the same race. Another nice thing about a mega study is that it allows for the large fixed costs of organizing a field experiment with high external validity to be borne by a single central organizer, which can lower the marginal cost to entry of individual scientists with interesting ideas who may not have the capacity to fundraise or run large experiments. Now they can be sort of brought in under this large organizing body and given the opportunity. Just like we think of maybe a behavioral lab at a university can have a fixed cost to recruiting survey respondents. A nice thing about testing many things at once, particularly when you have an urgent policy problem, is that it reduces the risk that you do a whole lot of work and no useful insight comes out the other side. It's the throw all the spaghetti at the wall and something is bound to stick kind of approach. And just like insurance pools risk in order to reduce bad outcomes, this is a way of pooling risk in order to reduce bad outcomes. It also allows for interdisciplinarity in a way that traditional science often doesn't. What we do in our mega studies is each scientific team will propose sort of a treatment and control. So they have their own study and it can exist as an island and they could go publish that in their preferred journal. A psychologist might choose Psych Science. An economist might choose Quarterly Journal of Economics. A marketing professor would choose their own preferred outlet and so on. Normally it's hard to get those people to agree and collaborate and sort of come together because they each want to talk to their audience. But if we run a mega study as a tournament, each can have their own study embedded in it as an island and can publish it in their preferred outlet, but they all are embedded in one giant study and sort of the meta-analysis of the whole thing ends up being publishable as well. And they end up seeing what other people did, even if they weren't part of each team. It can really speed things up. That was super important during COVID, right? We needed answers and we needed them fast. Instead of this sort of one at a time, we'll innovate on the last study and so on. This really accelerates things. Another element of mega studies that I will also just preview, I'm not going to have a lot of exciting results on this dimension yet, but in theory, and certainly as we move forward, one of the things that it provides an opportunity to do is use machine learning tools to ask what works best for whom, not just what works best on average. And we have many candidates. It's easier to sort of tailor and figure out what are the subpopulations that respond differently to different messages and how do we optimize for them. And then finally, and I think this is really important, especially in an age when we have a lot of concerns about replicability, one of the nice things about the mega study is that it creates an incentive and ensures that even our unexciting findings, even the dog that didn't bark, the intervention that didn't have a positive result, it gets published alongside the successful interventions, and we get all of that knowledge out there because there's interest in seeing the full suite of what's been tested. And so we have less of the sort of file drawer problem, things that didn't work being tried over and over again because no one bothers to publish what's a failure. Okay, just to give you a little history before I dive into sharing some data, I do think it's important to point out that this idea of the mega study, which our research team has been really excited to put out into the world, it's not that wild or different from many ideas that have already existed for a long time in the scientific literature. In particular, I think one of the most important predecessors to this is the Common Task Framework, which really revolutionized the field of AI about 15 years ago when it became the norm for researchers. It used to be that researchers at different labs who were solving a problem would each have their own data set where they would test and train their algorithms. So if you were an image recognition researcher, you might have your pet data set you were training on, and another research team would have a different data set. And you'd maybe have different algorithms that you're testing, but you also have different ways of measuring the quality of the algorithm. And so you have different validation methods to say how high quality was my solution. But what happened with the common task framework was researchers came together and sort of realized, hey, we should really be running our different algorithms on the same data set, using the same validation method, the same sort of criteria for quality. And then we're going to be able to make comparisons of how well do these algorithms fare and on the same problem. So that common task framework really accelerated science in AI, and it could clearly accelerate science in other domains as well. There's also been work on scientific tournaments as a way of sort of motivating teams, competing against each other, and seeing if they can generate better solutions. But in general, these kinds of tournaments don't involve random assignment, and we're going to do this as a random assignment trial. Okay, so I want to spend the rest of our time together sharing some data, and I'm going to do a tour of 3 different mega studies that we did that are going from sort of small and underpowered to massive and maybe even overpowered for measuring what we want to see. So just so you know, we're going to sort of go from, I wish I could differentiate better between these things, all the way to, wow, it's like I have the Hubble telescope. It's incredible. So the first study we did was focused on encouraging flu vaccinations. And this was done, I want to just be clear, this was done in the fall of 2020. The goal of the research, everyone involved agreed, was actually to develop innovations that would be useful for encouraging COVID vaccination. But COVID vaccines weren't yet ready. Flu vaccinations were being offered. It was comparable in many ways, though not in all, in that it was a respiratory virus where you needed to get a shot in order to be immunized. And so we thought, let's try out our best candidates with flu, and then we can turn around and we'll sort of have some recommendations for what we should say about COVID. So the first project was in partnership with Penn Medicine and Geisinger Health, which are 2 healthcare systems in the middle states sort of region of the US. We included almost 50,000 patients in this project, all of whom were scheduled to come in for healthy checkups. So they weren't coming in with a sore throat and fever, which would make them ineligible, for instance, for vaccination at that time. And our experimental design involved, we went out to many different scientists and they came up with 19 different messaging strategies that we're going to test in a sort of head-to-head race or a head-to-head competition. To be clear about the protocol, these messaging strategies involve text messages that were sent out to patients starting 3 days or up to 3 days, I should say, prior to their scheduled healthy visit. And they were in addition to the standard reminders that are being sent out that are business as usual, just about coming to the visit. These reminders are saying your doctor is going to offer you a flu vaccine, and we want to encourage you to take it. Okay, so you might be wondering, what are the kind of communications we tested? I won't go through all 19 because if I did, that would sort of take us to the end of our time together, but I'll try to give you a sampling. I already mentioned the idea of a joke about the flu. This was one I thought was particularly creative. Maybe we can make this lighthearted and sort of something that sticks with you. And hey, look, there's even, cats and dogs that are kind of funny. So who knows, maybe we can use humor for the win here. It said, have you heard the one about the flu? Don't spread it around. Actually, this is another version. We had a couple of variants that says, what good is a joke to keep to yourself? So, make sure you spread the word on this one. All right. And then we also had a version. So from the lighthearted to the more sentimental, another team proposed that we dedicate our marathon runs to other people. For instance, why not dedicate our flu shots? It asked people to text back the initials of someone they wanted to dedicate their flu shot to. And so that was another approach. Here's a really simple one that one team said, let's just make it sound really low hassle and recommended and like it already belongs to you, because we particularly tend to overvalue our possessions. So let's tell people a shot has been specifically reserved for you and encourage people to get that. We tested many, many more things. Like I said, there were 19 different variants. This is just trying to give you a flavor for the range of everything from interactivity to humor to really simple messaging. Okay. So first question, did we increase vaccination rates? Let me just acclimate you to this. graph, what you're going to see is that in the baseline condition, that's the business as usual group that didn't receive any additional reminders from us about accepting a flu vaccine when it's offered to them, 41.8% of patients were saying yes to their doctor and getting that flu shot. Okay, now what you can see here is what happens when we send text reminders. And I haven't yet shown you what one. I'm just showing you that this is the distribution of estimates of the benefits. So first of all, if I pool all of these estimates and say, just do reminders work, the answer is straightforward and it's yes. It's about a 2 percentage point increase in vaccination on average that we get just from reminding people 2 days in advance that they'll have the opportunity to get vaccinated and they should take it. We see a little bit of variability in how high quality these are. When we adjust for multiple hypothesis testing, actually, there's only one message that really survives. And that message is the simplest of our set. A flu vaccine has been reserved for you. And in fact, that reserved for you language was used in the 3 top performing messages and in none of the rest. So came out sort of, if you do a post hoc analysis, a very clear correlate of success in this case. The joke was our worst performer, which is good to know. A little bit disappointing for those of us who are bullish on jokes, but that's why we run tests. And the dedicate your flu shot to a loved one was kind of in the middle there. And there were lots of other things that were in the middle. Okay, so this first study suggests maybe that simple language like reserved for you that suggests ownership can be effective, but simultaneously we actually ran another mega study in a pretty different setting, and we tested some different ideas as well as some overlapping ideas. This one was done at Walmart Pharmacy, or in partnership with Walmart Pharmacy. It's going to be a lot bigger, so we'll have better ability to differentiate between different things we tested. The Walmart Pharmacy study, I should say, included 689,000 Walmart Pharmacy patients. And now it's a different decision. And this is part of why we ran the 2 mega studies. Instead of needing to convince people to say yes when they were already sitting in a doctor's office and offered a vaccine in a few days' time, we needed to convince people to actually make the effort to go into a pharmacy and request a vaccine. So they have to, get in their car and drive to the pharmacy when they wouldn't otherwise, or walk over to the pharmacy. So it's a different persuasion challenge, or a different action intention gap we need to close. And here we got different submissions. Again, everyone is targeting flu, but knowing that their real goal is to develop something that could be reused targeting COVID. And we tested 22 different messaging strategies in this context. All right, just to give you a little flavor for what we tested, one of the messages that was tested was really focused on why you should do this to help protect your friends and family. Because even if you feel healthy and like you're young and it'll be fine, there are other people whose decision who will be affected by your decision, right? And this was common messaging and something a lot of people were emphasizing, that we know, for instance, from past research done in hospitals, that often it's more effective to tell people, especially caregivers, to wash their hands for their patients, not for themselves. So maybe we should use the same messaging with vaccines. We also know from past research that telling people there's a social norm and that it's growing can be very compelling. If everyone else is doing it, I don't want to miss out. So truthfully, telling people that more Americans were getting the flu shot than ever in the last decade, and so you should do the same, was another thing we tested. And then we had language very similar to the reserve for you. We had just had to swap in slightly different wording. We tried waiting for you, and this was because of concerns about stockouts. So, but it's the same basic message. It's waiting for you, it's yours, and hopefully it conveys that there will be limited hassle, that it's already set aside for you, and it's highly recommended. And lots more as well here. So some interactive, some not. Some involve multiple reminders sent over the course of a week. Some involve just a single reminder. And then the question was, first of all, did this work? And here I'm going to show you another graph that looks at that question. Here, there was a holdout group, which was business as usual and didn't get these flu shot reminder messages. And they vaccinated at Walmart Pharmacy at a rate of 29.4%. Note, I should say that the people who were in this study were people who had received a flu vaccine from Walmart in a prior year. And that was to make sure that it wasn't perceived as marketing, but rather health-related communications. So I would have loved to have the whole world as our population, but that's the population we're working with. So that's part of why the baseline rate is fairly high. These are people who've gotten a vaccine at Walmart before, so they're coming in at a decent clip in the 30 days post-intervention. But how did we do with all these messages we tested? Well, here we have, remember, almost 1 million participants, And we have much better visibility into the specific effect sizes. And here we can actually much better differentiate between what works when we adjust for multiple hypothesis testing. We see that every single intervention tested significantly improves follow through. So reminders work about the same effect size on average in percent lift terms. And let's look a little bit at what works best. We do see significant differentiation between the best, between the different messages. So there's significant variation. It's not just noise around a general shift upward. And the best performer here, again, actually was that simple message: a flu shot is waiting for you at Walmart. And I believe 3 of the 4 top performing messages here use that message or that language of waiting for you, and the rest did not. So again, a very strong and clear sort of benefit from that waiting for you type reserved for you language, that ownership language. We also saw a clear relationship between multiple vaccine reminders and higher success rates. And more Americans getting the flu was decent. That performed well. It certainly helped, but it didn't rise to the very top. Okay. One interesting question we had the statistical precision to answer with this data set that we couldn't answer so well with the original, because there wasn't much variability between the messages that we could differentiate with our statistical power. But here we really can say, oh, this message is better than this other message with some assurance. And we wanted to see, could scientists predict our results? And we asked each of the 24 scientists who contributed to the design of these different intervention messages to predict what would the effect be of the messages. And we looked at the correlation between their predictions and the actual treatment effects. And what we found was that scientists couldn't predict what would work. So there was, if anything, a negative but insignificant correlation between their point estimates of treatment effects and actual treatment effects. Interestingly, they weren't overly optimistic about how big the effects would be, which is interesting because we've seen in past studies that often forecasters are overly optimistic, and we'll see that later in this deck too. But here, the team scientists were pretty well calibrated in terms of magnitude, just not in terms of the order and what would rise to the top. So that was interesting and suggests even experts can't figure this out, which is a good reason to have tests. But we also wanted to see, could lay forecasters figure this out? So we hired workers on Prolific to make forecasts as well. We told everyone what the baseline vaccination rate was, so they had some sense of magnitude to work from. And then we asked them to estimate which of the different messages that we sent would be how effective. And we actually found that they were quite good at predicting. So here, there's a very high correlation between their prediction, although they are overly optimistic about effect size, and the actual performance. However, they were not good at guessing our top performing message. It was, I believe, ranked 15th out of 22 on average. So while they could sort of tell the best from the worst, they couldn't pick out what was going to be the most cost effective. So a little bit of good news for forecasters and a little bit of good news if you think we really need to test. So sort of both views are supported. Forecasting can add a lot of value, but if we want to get the very best messages, it's still valuable to collect data. And experts aren't as good as the people who the messages are targeted at, it seems, in this context, at least, at forecasting, which is interesting in contrast with some past research. All right, so let me highlight some takeaways from these first 2 flu vaccine mega studies, and then talk a little bit about the work we did that was funded by SSRC and the Mercury project that built on these findings and another mega study. So as hopefully I have hammered home already, the big takeaway in terms of the language choice here was that ownership language did seem to reliably improve the performance of vaccine reminders. I should also just say that the reminders themselves are very, very effective, and just sending reminders is useful, and nagging seems to work. Multiple reminders are better than just one. We also did find in one post hoc analysis where we're just trying to look at sort of what are the features of the messages that sort of outperformed versus disappointed us in terms of their performance. And we found that informal and interactive texts, they were less effective than these sort of simpler texts. And that was more than just the ownership language being a simple text message. We see this across the board, across the messages. That interactivity, the sort of, popping in the jokes about with the dog and the cat pictures, that really didn't go well. As I mentioned, experts were not good at predicting ex ante what would work best, which suggests the need for tests or at least crowdsourced predictions as a better way to get at what will work. And you'll see from my next data that crowdsourced predictions can also lead us pretty far astray. I do want to highlight that even though these are small effects, the neat news is that if scaled, the 4 to 8% increases in vaccination we see from these kinds of reminders really could have a big difference or a big impact. They could lead to 6 to 12 million extra Americans vaccinated in a given flu or COVID season. So that's a lot of people who would have protection if we just do these very simple things. And we've gone around and pounded the pavement and presented these results at the White House in congressional testimony and so on to try to make sure that these best practices are being made clear by policymakers and also in industry. So you might be wondering, though, I just showed you a bunch of data about flu vaccination, and I told you it was all with the hope of being helpful in dealing with the COVID vaccine rollout. And you might be wondering, well, did it work? And the good news is it did. So there was a wonderful paper written actually by my former student who I'm very proud of, Hengchen Dai, a professor at UCLA, and Sylvia Sicardo and collaborators that came out in Nature that tested the use of ownership language in text reminder messages in UCLA's medical system in early 2021 when vaccines were first rolled out, and found that this was very successful, that using these text messages sped up the rate at which people got their vaccines. And there's another nice study done by one of our collaborators, Mitesh Patel, with caregivers in a health system that he was involved in overseeing, using these Reserve for You reminder messages there as well to encourage and accelerate COVID-19 vaccination adoption in the fall of 2021. So two separate validations, and we started seeing these messages in really wide use by city governments and also everyone from Walgreens to CVS taking it up. This is actually a flu shot message from earlier from last year, but we saw it in COVID messages and flu shot messaging that was widely used. So that was really exciting to see how quickly that rollout led to changes in the way people were communicating. But we were ambitious, and our hope was to do even more than lead to, say, at best, a 10% increase or a 2 to 4 percentage point boost in vaccination. We wondered, could we sort of swing a heavier bat at this important problem? Was there a bigger intervention we could deploy? And this is where our work that was funded by Project Mercury comes into play. And this is where we're going to talk a little bit about trying to encourage COVID boosters at the pharmacy. This is a mega study we ran last fall in November of 2022. And specifically, we wanted to tackle a barrier that had been widely discussed, which was transportation. So this study, I told you our study sizes would get bigger and bigger. This is going to involve 3.6 million patients around the US, which is pretty exciting. And we're going to give them free Lyft rides to get to the pharmacy in one of our conditions. We actually tested 8 different text messaging strategies. We figured, why not optimize our messaging approach even further than we have already? We had some new ideas that we wanted to test, but also we wanted to compare those messaging strategies against giving people a free Lyft ride to and from the pharmacy. So you might be wondering, why would we test free rides? Why is this where we would go? One thing we know is that small transaction costs matter a lot. Maybe that's the main takeaway from the last few decades of research in behavioral science. When we default people into things so there's no transaction costs, suddenly they do them at dramatically higher rates. Anything we can do to simplify processes is great. And vaccine accessibility, for good reason, has been a widely discussed challenge throughout the pandemic. A lot of attention to this issue. And we even have some correlational results from a wonderful postdoc here at the University of Pennsylvania, Asaf Mazar, in collaboration with Wendy Wood of USC, showing that people who live further from vaccination sites were less likely to get vaccinated against COVID-19. So again, suggesting this sort of transportation barrier might be a really important one. And of course, large investments were made in free rides without evaluation to and from vaccination sites in mid to late 2021. In fact, the White House sort of announced in mid 2021 partnerships with both Lyft and Uber to provide round trip free rides with some cap. And we thought, that's a great idea, but it would be nice to know what impact it had. And so that's part of what we baked into this mega study. So you might be wondering, what did those offers look like? So the first thing I should actually say is there's going to be a baseline message that we're building on top of. So if you can kind of ignore the text in black in this phone and just read the top part that's in blue, the standard message that we're going to build on just says, hi, Katie, updated COVID boosters are recommended to help prevent infection and severe illness. Your booster is waiting for you at, and then it would say the name of the pharmacy we partnered with. And then it would encourage you to claim or to schedule your appointment and gave you a link. When we added on top of that, we added a little bit of extra content, which told you that a free ride from the pharmacy had been reserved for you for your booster appointment and then there was an end date about 30 days in the future. And this was done with support from the Mercury Project. And then we invited them to schedule, and then we told them that they could claim their free ride by either entering a personal code we gave them or just literally clicking a link in our message. So if they clicked that link, what it did is it opened the Lyft app if they'd already downloaded it, and then I've blanked out the name of the pharmacy because we don't yet have permission to name them. Our pharmacy partner would say the name of that pharmacy and say pharmacy vaccine team gave you a Lyft pass for San Francisco area. And then it would say the pharmacies. And this is, I should say, this is only if you were in the San Francisco area. If you were in the New York area, this would say for New York area. So we did geocode, and you would be given free rides to and from pharmacies in your area. And then if you actually opened your app to try to type in an address, if you typed in the address of one of those pharmacies, then you would be able to see that that ride would be free because we had automatically now applied this to you. You could also go and see sort of the scope of this and where exactly the free rides would take you in another part of the app. If you didn't already have Lyft downloaded, you could go ahead and download it and then click the link, or you could manually type in a short code and all the same things would happen. So we tried to make it as easy as possible, and this sort of mirrors the way that the White House program was rolled out. All right, you might be wondering though, what else did we test? Because I said it's a mega study and we were going to play with more than just free rides, and we did. We tested a few other ideas too. We tested, for instance, saying, hi, updated boosters are recommended, and then suggesting that it helps to make a plan. And then we would pipe in a suggested plan, a default plan. Here we told the person the day of the week, the time of day, and the location of the pharmacy where they got their last vaccination in our records. So we were suggesting a good default plan. We also tried telling people that there was significant current transmission in their county, and we'd say the name of their county. And if they were in a county where the infection rates were in the top half of the US, we'd tell them their decile of infections. We tried encouraging getting protection for the holidays, letting them know that this could protect other loved ones, and the holiday season was just a little ways away. And we also tried providing information or misinformation resources to combat misconceptions so that they could call a pharmacist or they could go to a CDC website and get information if they had questions. And more, but those are a few of the things we tested. Okay, so how did this go? So first of all, I want to just say we had very low baseline vaccination rates in this particular study, which was done in November of 2022 and looked at 30 days after the start of the study at the beginning of that month of COVID booster vaccination. So it was about a 5% rate at which people were going in those 30 days to get their COVID boosters. So it was a different moment in the pandemic than the other studies in terms of the flu shot take-up. So that's the baseline we're going to be working with. And the first thing I wanted to show you is the distribution and also how our sort of best practice reminder that was based on past work looked. So here you can see we tried the simple message, updated COVID boosters are recommended. Your booster is waiting for you. Everything we tested significantly improved outcomes, even when correcting for multiple comparisons. This is the great thing about really large data sets. So these are all very significant results. But the best performer wasn't actually what was sort of based on best practice. We did manage to improve by adding some extra features, bells and whistles to that reminder message here. But notably, despite what experts and lay people predicted would be our top performer and what we predicted, which is what motivated us to do this research, we did not see any benefit of layering on a free ride to and from the pharmacy with a Lyft, none whatsoever. There's nothing happening, as you can see pretty precisely from this graph. It's not a help. What did help? Well, that suggestion to make a plan and offering a default plan based on the last time you went was significantly better than the baseline message. And the sort of scare tactic of telling you you're in a county with a lot of transmission right now, and telling you you're decile if you were in the top half, that worked. Telling people where they could find facts to combat misinformation or encouraging them to avoid infecting loved ones over the holidays was less effective. And there is significant differentiability between the different messages. Although the biggest benefit, I should say, the majority of the bump, as you can see pretty clearly in this graph, is coming from sending a reminder in the first place rather than from the exact wording of the reminder, though we can eke out a bit of extra benefit when we word our reminders more effectively. Okay, I do want to highlight one last thing about this study before getting into a literal heterogeneity analysis, and I promise I'll wrap up soon because I know we want to get to Q&A. But this best performer, this is what it looked like, and I'm very excited that one of my amazing PhD students here at Wharton, Rob Kwan, has been doing some follow-up work to try to explore whether any old default would work or whether this personalized default is what makes this planning prompt so effective. And it seems like any good default from our really preliminary read of a follow-up study may be quite useful, and that it's really the default that's doing the heavy lifting. Of a reasonable default makes it easier for you to click schedule and follow through, because you don't have to think through the complexity of planning. Oh yeah, when am I going to do this and where am I going to do this? We can simplify that for you. So that's kind of an exciting bit of work in progress. One thing that we were all very intrigued to explore was whether or not there would be heterogeneity, meaning different subpopulations would react differently to the messages. The first thing I want to say is that there's enormous correlation across subgroups in, across subgroups in how the different interventions move the needle. So if men responded better, for instance, to one message, women also tended to respond better. In fact, the correlation in the effectiveness of the 8 different vaccines across different subpopulations on average is 0.93, which is just incredibly high. So these things are really there. It doesn't look like we need to tailor necessarily to the subpopulation. However, there are some subpopulations that are generally more responsive overall across all of the different reminders, or less responsive. And that's what I want to focus on here. I'm going to pool all the types of reminders, though it's broken out in our paper. Trust me that there's not anything interesting if you break it out. It's really the same pattern, just over and over and over again. But what we see here is that there are bigger effects of reminders for men, much bigger of effects of reminders for older populations, people who've gotten 1 or more boosters in the past, so they've revealed themselves to be open to boosters, more than triple the benefit of folks who haven't gotten boosters before of sending these reminders. Medicare beneficiaries are showing much bigger responses to reminders, and those with unknown insurance. We also actually, and this isn't in this graph, but we also see that people who have been texted on the same short code that was used for this reminder by their pharmacy before, which may be just a proxy for sort of pharmacy loyalty, meaning they have interacted before, maybe trust of this message, they also showed bigger benefits. Could lay people predict what would happen here? Were they any better at predicting what happened here, just like they were so good at predicting what happened with our flu shot study? Well, the answer is no. And that pink car is actually a data point. So sorry if that's not super clear, that's on a data point. And what it's showing you is predicted treatment effects were biggest. That was by far lay people's prediction was that free rides would work best. And of course, we saw they didn't, and they had no correlation with the others really either. They also were wildly overly optimistic, even though we told them what the baseline vaccination rates were. So they're way out of, they're thinking there's going to be a 20 percentage point boost. You might say that's crazy. Who are these people? These are the same exact people who gave us pretty good forecasts for flu vaccination. There, they were overly optimistic too, though. And even if we sort of rein it in and throw out the data from people who gave us estimates of more than, say, 2 percentage point treatment effects, we see really the same thing, no correlation, and they expect the free ride to be the best. So that's, I think, pretty interesting. Could experts predict results here? Also, no. Experts also were very bullish about the free rides. There's a little correlation at least, but it's not significant. So maybe slightly better than lay people, but not statistically speaking. So let me wrap up here. I think I went a little over my allotted time, but last couple slides. Hopefully, you were interested in the takeaways from this mega study. We found them very surprising. Contrary to our expectations, the expectations of lay forecasters and experts, what we find is very convincingly that a behaviorally informed reminder is just as useful as a free ride. The free ride really wasn't adding the value we expected it to add. We also see that reminders had bigger effects for men, Medicare beneficiaries, those with prior boosters, those with unknown insurance, and older adults. So these are some populations where we really want to make sure we're getting out reminders. That another thing that was kind of neat that we found in this data is that when we reminded people to get a COVID vaccine, there was a spillover effect, and that led to a 7% increase in flu vaccinations, not 7 percentage point, but 7%. So that was really nice that we could estimate that. And we also saw that this test produced an extra 33,000 roughly COVID boosters and 9,700 flu vaccinations. So very excited that just we can tell from the reminders we send, the extra vaccinations produce that this mattered. And if you scale it up even more, we could have an even bigger benefit. So let me wrap up on this slide. I hope I have convinced you that mega studies have some value, that they can accelerate scientific discovery, especially when there's a pressing policy problem like getting better at communicating about encouraging vaccination. They let us compare apples to apples. They reduce the risk of doing expensive research because it's more likely you'll find at least something useful when you pool and test many ideas, and the fixed costs can be borne by a single organizer. They facilitate interdisciplinary collaboration, and they can lead to policy recommendations that are better than what we generate if we just use expert intuition or even lay intuition, it turns out, across our studies. I do want to highlight there are limitations. These are not the only way to do good science, nor are they the right way for all science to be done moving forward. They're just a new tool in our toolkit. They can be really hard to implement. They're costly designs. They make it harder for one person with a good idea and a small budget to go out and make an impact. You can't do a mega study under those conditions. They really require big sample sizes. As you saw, even the 50,000 people in our initial study with Penn Medicine and Geisinger Health was really too small to do what we wanted to do well. It needed big national pharmacy chain partners to do what we had hoped and to have the precision and estimates we needed. They require central coordination, which is a big challenge in many cases. And another thing I want to highlight is that when we do these, just like in a meta-analysis or anytime if you threw darts, right, the top performer is almost certainly overestimated due to the winner's curse. Now, we can correct for that statistically using the James Stein shrinkage procedure and do in our published work, but it can lead to false expectations if people don't realize when they test many ideas at once that they're not likely to see a replication of the biggest effect size in a given study if they roll it out at scale. Okay, let me wrap up here and just thank our funders, particularly the Social Science Research Council and Mercury Project, which made this work possible. The amazing staff at the Behavior Change for Good initiative, my partner in crime on all of this work, Angela Duckworth, my amazing co-authors, and our research partners, Walmart, Geisinger, Penn Medicine, Lyft, and CVS Pharmacy. And with that, I would love to take your questions.
Okay, well, thanks so much, Katie. And I think this is the first time that I've heard the results from the Mercury Project study. I heard about them. This is the first time I've seen you present them, so that was great. All right, so we have a bunch of questions here. Some are specifically about your work, and some are about the infrastructure for doing meta studies. So I'm going to start. We have a question here actually from Mushfiq Mubarak, who's doing some work on transportation in the context of vaccination, but in a different context. So Mushfiq has two questions here. The first is, can you talk about the cost effectiveness of the Lyft treatment, the Lyft rides? So what would the increase in vaccination rates have to be from offering the free rides for that to be a cost-effective strategy? Do you have any sense of that?
It created essentially no extra vaccinations, right? So it would have to be free and it still wouldn't create value, is what we found, right? You're better off just sending a good reminder, essentially, or they're tied. So there's no there's sort of no cost at which it makes sense in this context. I want to be super clear that that's in the United States. I also sort of said this is with in 65 metropolitan areas where we ran our test. So we didn't look at this in rural areas. Some of the metropolitan areas included, exurbs, but not like really rural areas. So and it's also, this is the value of a Lyft ride, could be different if it were a taxi, if it were public transit, but we're nowhere near sort of a cost-effective frontier for this.
I think the question was more about what would the increase have to be.
Oh, I see what you're saying.
Order
To make
for it to
it
be
cost effective. Well, then it would depend on what you think the value of the vaccination is, right? So you have to think about like what do you think the right cost is? The rides we gave out, we capped the price at $25 per ride, so it would have been a total possible cost for us of up to $50. But we've done a bunch of trying to calculate, like, what's the expected cost if it had been widely adopted, given where people live and so on. We would probably expect the round trip cost to be closer to something like $20 or $25 total. And it certainly makes sense that I've never seen anyone value a vaccine at less than that. So if it were having an effect, it would be cost effective, I guess is the short answer, which is why we wanted to test it.
Right.
But and that's why I think the White House was happy to roll this out as a policy, because the upside was high, but it turned out that I think what we ended up doing probably is just giving people free rides to visit their friends near vaccination sites.
And he has a follow-up question. Do you think have you ever thought about whether it makes sense to take the vaccination to people, whether that could be an effective strategy in the settings in which you've worked, as opposed to having them come to the pharmacy?
That was honestly what we wanted to do, right? That I think that would, my strong intuition is that's much lower friction than giving you a free ride round trip, is to just bring it to your doorstep. I wrote an op-ed in The Economist in fall of 2020 saying, like, let's put these things in, let's buy, I was sort of joking, but sort of not joking. I was like, let's buy fleets of ice cream trucks and bring them to every corner and give people an ice cream cone when they get one. I was joking, but I do think that would be great. Let's make the transaction cost as low as possible. I still have to get into an Uber and order it. That's nowhere near as nice as if somebody knocks on the door. But we did explore that a little bit for various reasons. It really wasn't feasible in this context. Getting licensed and trusted people to show up, and you're going to knock on a lot of doors and have people not home, or they've already gotten the vaccine, or they don't want it. It's just very inefficient in some ways that led us not to go down that path. But I would love to in a dream world.
Yeah. And then here's another question about the transportation. Do you think it might, presumably you weren't able to evaluate the Lyft treatment in rural areas that just don't have Lyft, right? So do you have any sense of whether transportation might have had a bigger impact, right? Had you been able to test it?
Yeah, it's an absolutely terrific question. We did hope we'd be able to get at that, at least with the variation in how densely populated the sub. So it's in metropolitan areas, but like I said, they have exurbs, right? And some metropolitan areas are much more densely populated than others, right? I live in a very densely populated urban area, Philadelphia. I can walk to like 6 CVS's from my house. I can walk to 2 Rite Aids. I can walk to several Walgreens. It's super easy. And that's really different than, I think you were just in Minneapolis, right? And like a lot of the density of the urban core, it doesn't look the same way. You still have to get in a car in LA. And then there's, also exurbs where really it's not densely populated at all. And it's not just that you need to get in a car, it's that you need to get in a car and go a really long distance. So we do have that kind of variation, and we do not see differences along those dimensions, which makes me think that we might not see anything different in rural tests, but I don't know for sure without doing the rural test, which wasn't feasible because Lyft just doesn't have, if you go to a rural place like Montana, Lyft isn't going to be able to offer strong service. And so you're going to try to call Lyft and not get one.
Yeah. So here's a question that kind of bridges the work that you've done, and I think maybe implicitly a bigger meta question about mega studies. So then the narrower question is about whether in any of these studies or in any work that you have going on now, you're able to compare the effectiveness of these one way, text, not necessarily one way, but these text-based nudges, treatments to other forms of media, right? Whether it's like WHO has been experimenting, whether it's social media or radio or face to face or these other ways of delivering of communicating pro-vaccination messages. But maybe the bigger question is also about when you talk about the comparability of treatment effects in a mega study, is what you mean comparability within a relatively narrow set of things that are all very alike in terms of the modality with which they're communicated.
So there's no reason a megastudy needs to be in one modality. And in fact, you're anticipating some of our upcoming work, which will be testing multimodal and exploring how, what's the cost effectiveness and absolute effectiveness of some of these different modalities. So there's no reason for a megastudy to be one modality. It's just that that's what the ones I presented today happened to be. It was very convenient with each of our partners to be able to do this via text. There is some work in political science that looks at this modality question for get out the vote. I haven't seen apples to apples comparisons yet in vaccination, which is part of why we think it's right for a test. But in the get out the vote space, it runs the gamut from sort of knocks on doors, which are most effective in an absolute sense, but not super cost effective necessarily. They're actually similar in cost effectiveness to much cheaper methods like physical mail and text messages, only because it costs so much more to send a human. Mm-hmm. So even though it's more beneficial to have the face-to-face contact, it's so much more expensive that you end up kind of in the same spot in the end. And I think emails have been shown to basically have no impact on behavior change at this point, which is borne out by some of our recent attempts at email mega studies have been very disappointing. So it seems like text messaging still has some potency. I would love to do a mega study with mail. I'd love to do a mega study with door-to-door. These are the kinds of things we're thinking about. But from the work in poli-sci, we have a sense that that you'd get some benefit from that face-to-face, just at high cost.
So there's a bunch of people in the Q&A interested in the infrastructure for the kind of work that you do. Could you say, so obviously it's it requires infrastructure, right? And you said this towards the end, that this is not that there's a big fixed cost to setting up the architecture and the apparatus, right, to conduct these. So could you say a little bit about how you got started? And people are asking, like, where did the funding come from, and who gets to be an affiliate, and lots of nitty-gritty things that you won't have time to get to, but maybe just tell a little bit of the story.
Well, the story of our of us getting started is actually a fun story about how funders can change the course of research programs. So the origin story is that Angela Duckworth, who's my partner in crime on all this work, and I think we're literally sitting in a meeting together talking about behavior change when we got an email from the University of Pennsylvania's president, then Amy Gutman, about an internal competition she was launching because the MacArthur Foundation had announced they were going to give out $100 million for a team that could make important progress on a major social problem. And every university could only put forth one proposal. So there was going to be an internal competition at Penn. And Angela and I are very competitive. And we'd also been thinking a lot about behavior change. And we sort of looked at each other and we're like, you know what? Behavior change is a major social problem. It lies at the heart of almost everything we need to get right, from, how do we transition to, a greener, more climate friendly planet, to how do we, save enough for retirement, achieve more at school and at work, manage our health, et cetera. So we put forward a proposal. We made it pretty far, which was really exciting. We did several rounds in the competition, but not to the end. So we did not win. They gave the money to Sesame Street to make programming for Syrian refugee children, which, great cause, totally different approach to using that. But we were so excited, and we'd sort of built this team in collaboration. The idea of building out mega studies as a way to accelerate the scientific progress we could make on these pressing problems, and got some seed funding from the university, and turned to some generous granting agencies like SSRC and the Mercury Project that have since footed the bill for these mega studies. And we do have an amazing team and staff. We have a staff of 8, 4 PhD scientists who really understand all the things that have to go right and help us make the magic. And then for research assistants who are sort of heading to PhD programs and getting a little training on the way. And then we work with amazing organizations that create infrastructure and opportunities and make it possible to do this, because they need to have the technology on their end to interface with, in these cases, their patients, and let us piggyback on that and A/B test. So it's a lot. But if people are interested, bcfg.upenn or upenn.bcfg.edu, I think, is our website. That might be wrong. You can look up the Behavior Change for Good.
Just Google Behavior Change for Good initiative.
And you'll get the right link if I just gave you the wrong one. And you can learn more about the team, which is constantly growing. We went from 30 who submitted the original grant to something like 175, and we're constantly bringing in new interdisciplinary team members. So yeah.
Well, Katie, we have a ton of questions here we haven't had a chance to get to because we're out of time, but we're going to send you the everything in the chat and the Q&A so you have a chance to see the questions. And thank you to everybody for joining us. It was so great to wrap up these centennial lectures with this, I think, very optimistic view of the progress that we've made in the last 100 years in terms of how, thinking constructively about how not just to describe problems, but also come up with solutions to them. So thanks, Katie, for joining us.
Thank you for having me and for all the work you do. Appreciate it. It was a great event. Fun to be here.
Great. All right. Thanks, everybody. Thanks for joining us. We'll see you the next time we do one of these. All right. Bye-bye.